Thanks. Hey, everyone. So let me first introduce our speaker today. Dr. Jacob Aptekar is a Vice President of Trial Design Solution at Acorn AI, which is a part of a Medidata company and also part of Dassault Systems. Dr. Aptekar has over 10 years of experience as a basic science researcher, business leader, and data scientist. He has a very interesting background. He worked at he used to work at the McKinsey Company for, I guess, consulting for different healthcare technology and therapeutic design. And then he also founded his own company, Qurator Inc., a data science company focused on progression of chronic kidney disease and care planning for dialysis. And Dr. Aptekar's education background is quite unique, and he has a MD from UCLA and also a PhD in neuroscience from UCLA. And he was an investigator from Howard Hughes Medical Institute and a Bachelor of Arts in Physics from Harvard College. And he's also a collaborator of mine. I'm so happy that he's here to give him a guest lecture to our students. So Jacob, the floor is yours.
Yeah, thanks everyone. And I should clarify, I was not a Howard Hughes medical investigator, but my PI during my PhD was. But yeah, it was great.
Oh, sorry.
Very nice to be here and meet everyone. And so I put together a lecture today. We'll get into some technical topics, but I'm also going to spend a lot of time trying to talk about how machine learning actually sort of like fits into this particular area of medicine and how we've gone about defining a problem that we think we can have a really differentiated approach to, and then actually developing that approach. And that I think is going to be, particularly if the group really, if we have a little bit of time for discussion at the end, and I know there were some questions you all submitted before, that's something I'd really love to talk about, because I think my general philosophy of data science and honestly sort of science in general is that it's not how difficult a problem is doesn't necessarily relate to how important it is. And the real challenge, I think, is finding important problems where the techniques that you all are learning can have the greatest impact. And that's ultimately what allows you to have a lot of resources at your disposal, and then ultimately, change the world. So that's what inspires me about the sort of work that I do. Oh, actually, so it says the host has disabled participant screen sharing. So Jiwang, do you think you could allow me to share my screen? There we go. Yeah, I think there we go. I got it. Good. Why is that? We'll go into slideshow mode. Okay, so the topic of this talk is all about making cell therapy safer and more accessible, and those are all terms and technologies that I'll be defining. So, what is cell therapy? What does it mean to be safe? And then ultimately, how does making these drugs safer mean that more people can access them? And we're going to be focusing on a particular condition that is prevalent or common in the case of cell therapy, which is called cytokine release syndrome, which has to do with an overactivation of the immune system. So I wanted to start off just with a very high level description of the biotechnology that we're going to be spending a lot of our time talking about, which is called CAR T therapy or CAR T cell cancer therapy. So maybe 2 decades ago, there was a recognition that one of the reasons that cancer avoids being detected by the body is that it prevents the immune system from actually interacting with the cancer cells itself. And there's sort of 2 sides to this equation. One is that the cancer cells produce molecules called that activate immune checkpoints, which basically tell the immune cells, don't look over here. There's sort of nothing to see here. Don't look at the cancer. It's just more example of healthy normal tissue. And then the other side of the equation is that the immune system is sometimes not that good at actually producing immune cells that know to target cancer. And so CAR T cell therapy, which stands for chimeric antigen receptor T cell therapy, is fundamentally a therapy about taking a patient's own T cells out of their body. So you actually, the first step of this treatment is called leukapheresis. You actually remove the patient's blood, you run it through a centrifuge, you spin out all the white cells, and then you use a technique to separate those cells into different cell types, and you identify the T cells. And then there's a genetic reprogramming that's done by the drug companies. So they actually have a virus that will infect or transfect those T cells. So these are sort of normal T cells from your body. And what it will cause is that those T cells will express a sort of modified version of an antibody on their surface. And that antibody has been designed to go after particular proteins that we know these cancers are going to produce lots of. So, and a lot of the examples that we're going to talk about focus on a protein called, or a cell surface protein called CD19. But CD19 is a protein that normal B cells express in the body, and B cells are a component of the immune system. But for the purposes of the diseases we're going to be talking about, there are certain types of cancer, specifically lymphoma and leukemia, where the actual cancer cells themselves express lots of the CD19 protein. So take the cells out of the person, reprogram them to have a new cell surface protein, which you can see here, which is an antibody against CD19. And then what that does is when you put the, so then we'll go to the next few pieces. Then there's basically a conditioning and expansion. This has to do with basically preparing the T cells to be reinfused into the body by exposing them to antigen and allowing them to, taking a small number of cells, which you take out of the patient, and turning that into millions. Then there's something called conditioning, which is for the host, again, the person with the cancer, in order to prevent their immune system from rejecting these cells when they're put back into the body. They give them some chemotherapy to actually reduce the number of circulating immune cells and lymphocytes in the body. But this is similar to bone marrow transplant. It's basically high intensity chemotherapy that's designed to suppress the host immune system. And there's readministration of the CAR T cells where they're given back to the patient, and there's monitoring. And because these cells are so effective at interacting with the tumors, very effective at killing the tumors, that interaction causes lots of signaling molecules to be produced that drive further inflammation, and those are called cytokines. And cytokine release syndrome is a condition where basically those interactions of the CAR T cells with the tumor are so exuberant that that number of cytokines that's produced causes basically patients to experience sepsis, which like basically a multi-system organ failure, and ultimately in some cases it can lead to death. So this is the approach. Why people are excited about this? So this is an article from 2017. The first patient was treated with CAR T in 2012. It is a very effective type of therapy for very difficult to treat cancer. So it's quite expensive to administer this type of treatment, but for the patients that it helps, it can have a very profound effect. This is the first patient who was successfully treated with CAR T. Her name is Emily Whitehead. She was treated at the University of Pennsylvania in 2012. And this is just an article that was put out by CHOP. CHOP is the Children's Hospital of Philadelphia, so the Penn Associated Children's Hospital, marking 10 years for her of disease-free remission. So basically a cure as a result of receiving this cell therapy. And for her, even 10 years after the fact, you can still detect the CAR T cells in her blood. So basically this genetically engineered personalized medicine is still sort of circulating in her body. So if we look over the last, say, 6 or 7 years, there's been like a rapid amount of expansion in these drugs being tested in humans, brought to market, and then ultimately used to treat cancer. So I mentioned that CD19 is the most common, has been the most common antigen that these cells have targeted. The first drug to come to market was called Kymriah, that was developed by Novartis. Then there was Yescarta, which was developed by a company called Kite, and Tecartus and Breyanzi, which were, Tecartus was also developed by Kite, and then Breyanzi was developed by Bristol Myers Squibb. And then in the last couple of years, there have been new therapies that are targeting new types of antigens. And the new antigen that Beckman and Carvykti are going after is something called BCMA, which is related to another type of cancer called multiple myeloma. But essentially, over the last 10 years, the amount of clinical development in the space has gone from essentially nothing or very, very little to 700 active studies and 75 different companies that are all like large companies that have raised a significant amount of money that are all developing therapies in this area. And so for us, what makes this an exciting place to focus in or to learn about is that we're really at this sort of inflection point in terms of the amount of data that's available and the level of adoption of this type of treatment. But there is actually not that much clinical experience. So today, in the whole history of CAR T, there's only been about 15,000 patients treated, which is a very small number, really, relative to any sort of treatment that treats conditions that are quite as common as this. So where does metadata fit into this whole process? So metadata has been around for about 20 years. We produce software, we build software that allows drug companies to collect the data from their clinical trials. They actually use this at the point of care for every patient interaction. So there's a bunch of, in a clinical trial, it's essentially a big experiment. You have planned interactions with patients, you collect objective measures, patient-reported measures, at a number of different visits, laboratory tests, vital signs, tumor samples, et cetera. And record all that into a software system called an electronic data capture system. And that's been Rave's sort of flagship product for about 2 decades. About a decade ago or 12 years ago, Medidata started asking sponsors if they would opt to share the data that was collected within that platform, and the vast majority of those sponsors agreed. So about 90% of the sponsors on the platform share their data in some form to allow the group to sort of gain collected insights. And that's all based off of essentially 3 principles. One is generosity, which is that the sponsors who share data have the ability to access the data that is shared by the others. We call this a give to get type of model. The second principle is something called stewardship, which is that we take very seriously that we handle this data, which is personal health information from clinical trial participants, in a way that's designed to protect their privacy, that's designed to protect the intellectual property and value of the sponsors, the actual drug companies themselves. And then the third piece that really underpins all of this work is that we have to enable the people that are the companies that are sharing their data to mine it, to learn from it in order to design better clinical development programs. So we have been very active in aggregating clinical trial data in this area for the last basically 3 years since I joined the company. And this is just an example of showing the scale of patients within any single clinical trial. These are not necessarily all within Medidata's platform. These are just representative trials that are some of the larger trials in the space. So the typical clinical trial that has been run in this area is enrolling a few dozen patients, or in the very largest trials, around 100 will receive CAR T therapy. But in total, because so many of these have run on our platform, Medidata has several thousand patients that have been treated. And just as another example, if we look at the 3 sponsors that have the most data in this space, Bristol Myers Squibb, Gilead, and Kite, to date, they have around 1,000 subjects each who've been treated with CAR T that they have in their database. But the median, if you look at that 75 different companies, that that are working in CAR T, most of them have data on less than 15 subjects. And so this presents a real challenge for them for all of those companies to design the next phase of trials because they have so little experience and so little knowledge of what to expect. And this is one of the places where data can be so powerful, because obviously if you know what to expect, or if you understand how similar patients have responded in the past to treatment, it can make a very big difference to how you design treatment in the future. And this is a little bit more granular, but at the moment, what we are sort of working with and where we're currently actively working with sponsors is about 4,000 patients worth of data, 50 trials, and then a distribution of different products which focus on CD19 as well as BCMA, and then a class of therapy here which we call BiTEs or DARTs or T-cell engaging therapies, which you think about what the difference if CAR T is sort of personalized medicine, where you use a virus to introduce a gene into a cell that makes it very good at attacking a tumor. A TCE is basically like a little adapter molecule that goes on to the pre-existing T-cell receptors on circulating T cells. It's like a little adapter molecule that fits on there that basically makes it makes it more avid towards or more likely to bind the tumor cells. So in that sense, it doesn't require gene modification, but it achieves a similar effect therapeutically. Okay. So that's sort of the market and the reason why data might make a difference, and just sort of the general landscape, that there's this pretty significant asymmetry between companies that have some level of clinical experience and companies that don't. But in general, there's just a general lack of available data. So the way that we have sort of focused on understanding the ways that this data can lead to better trials is through a process that roughly mirrors the way that clinical trials operate from the patient's perspective. So the first thing is called patient selection, and this is about finding and recommending an investigational therapy for the right type of patient. And we'll talk about some ways that sort of analytics and machine learning can help there. Then there is something called bridging therapy, which is once the patients actually have those cells taken out of their body, there's typically a manufacturing interval that can be anywhere from 2 weeks to about 8 weeks, where those cells, their T cells, are being transformed and expanded and prepared for reinfusion. But during that 8-week period, you have a patient who has active, in often cases, fairly aggressive cancer that has to be managed, and there's a period of bridging therapy. And optimal bridging therapy can be very important to patient outcomes. Then there's lymphodepletion, which we called conditioning previously, but this is this idea that you give chemotherapy right before, about a week before giving the cells back. And you need to suppress the immune system, and there's a lot of choices associated with that. Then there's CAR T infusion, which I think is self-explanatory, but you give the cells, and then ultimately there's recovery. And recovery sort of has two phases. One is the acute phase, where the immune system of the patient is suppressed, where the CAR T cells have been introduced and they're beginning to expand and they're actively attacking the cancer. And then there's a more longer-term phase of recovery, where that initial sort of burst of activation of the CAR T cells has passed, the immune system has begun to recover, but now you have to sort of think about whether there will be prolonged remission, basically like how well the cancer will be managed over the long term. Okay. So I wanted to go a little bit more into actually the patient journey, because for me, this has been a really useful way to understand how machine learning and how data can actually make a difference to real patients. So CAR T patients come in lots of different ages and sizes. Old people, young people, children, young adults, depending on the cancer. All these are and typically they're coming to CAR T after a very difficult treatment course. And it's very difficult to know because of the lack of clinical experience how any one of those individuals is likely to respond. But the general principle that we apply is that we know that making personalized medicine for one individual, we can do that better if we understand how similar individuals have responded in the past. So on the one hand, personalized medicine is about making, a drug for every single individual patient and personalizing it to their experience. But on the other hand, it's very hard to make any of those decisions rationally if you don't have some knowledge about how similar patients have responded in the past. And so the core of the value that we bring here is learning from the combined experience from many different sponsors, from many different disease conditions, in order to treat any one patient and their particular journey. And now if we actually look at the journey of one of these trial participants, there are these different phases. So there's the patient selection phase, which is typically relapse and enrollment. So the cancer comes back and then they enroll in the trial. Then there is the actual sort of manufacturing phase of treatment. There's the treatment and acute management phase. So when you actually give the cells back to the patient, now they're in the hospital and you actually have to make sure that if they have a severe adverse reaction, you're prepared to manage it. And then finally, there's sort of long-term follow-up and hopefully long-term control, and then ultimately sort of return to the life that they had been living before. This is sort of the goal. And when we look at our data set, we have these journeys for basically thousands of patients. And so what we're looking at are ways to model these journeys and make sure that we can make every decision along that process in the most optimal way possible in order to make the best outcomes for the patient or to make the best outcomes for the sponsor. And again, the sponsor's motivation in many cases, or in almost all cases, is to bring these drugs to market and have them widely used. But that can't happen basically if they're not delivering a good care experience and good outcomes to their individual patients. And then I'm going to get into some stuff that will start looking a little bit more like data science, and we'll sort of, and you'll start to sort of see the sort of general thought process, and then we'll go into these individual steps so you can understand how we're optimizing some of these care decisions. So here's an example of looking at patient selection. So this is something that was observed in 2019 is that patients who were enrolling in clinical trials for CAR T were doing very well. And in the clinical trial development process, typically in a phase 2 trial or an earlier stage trial, they are what you call single-armed, which means that so the way that many people think about clinical trials is what's called a randomized controlled trial, which is that patients come into the trial and every patient basically picks a number out of a hat, and based off of how that number has been randomly assigned, they are randomly given either a standard of care treatment or a placebo, or they're given the experimental drug, which in this case would be CAR T. In a single arm trial, and that allows you to control for a lot of different variants that might exist, because you're essentially leveraging randomization to achieve balance between the patients who are receiving standard of care and those who are receiving the experimental therapy. Early on in clinical development, trials are single armed, which means you only give CAR T therapy to everybody. I mean, everyone who enrolls in the trial gets CAR T therapy. But now you have the issue of selection bias that can have pretty profound effects. So, for example, the patients who are the most able and motivated to seek treatment are often more likely to have good outcomes due to many factors that are unrelated to the severity of their disease. But one thing that's been very interesting, so this is a condition called DLBCL, which is diffuse large B-cell lymphoma, which is probably the largest condition where CAR T is used. And what this chart shows is proportion of patients surviving after some amount of time. So this is 8 years after treatment versus 0 years after treatment. It starts at 100%, and then these look like they're going to about 40%. So So the patients who enroll in clinical trials for DLBCL, this is a very large sample size. So all told, this is about, it's a little over 100,000 patients. This is not just CAR T trials, but this is all trials related to DLBCL. So the patients that enroll and receive treatment 30 days or after they initially enroll, they have significantly higher survival. This line basically stays higher over time than those patients who receive treatment within just 7 days. Now this is sort of counterintuitive, because what you might think is that receiving treatment sooner is better. But what these investigators actually looked into was the fact that the most severe patients, because of concerns about the effect that delay in treatment may have on their disease progression, the most severe patients are not willing to wait for 30 days to receive treatment. So what you don't see here is all the patients who enrolled in the 30-day trials but disenrolled, basically took themselves out of the pool because they weren't going to receive treatment quickly enough, and basically went on to whatever treatment their oncologist was able to prescribe to them. So those individuals basically who are able and willing to wait for a long period of time to receive treatment tend to do much better. And those patients who enroll in trials where they're treated very rapidly are essentially enriched for patients who have higher risk disease, for two reasons, probably. One, because investigators are more likely to recommend them to these trials because they know they'll be treated very quickly. And the second reason is that they don't disenroll. This is just meaning to say that every decision in the process, so something as simple as designing a clinical protocol where the interval between enrollment and treatment is 1 week versus 4 weeks, may have a very significant impact on the actual signal you're able to detect. So just to sort of play this through the context of a single arm trial, CAR T often takes a very long time to give to these patients. It can take as long as 8 weeks. If you, for example, had a clinical trial where everyone enrolled and received treatment 8 weeks later, what this is basically showing is you might expect those patients to follow the black line in terms of their disease prognosis, independent of what treatment they're receiving. Whereas if you treated them sooner, you'd actually enroll sicker patients, they would do worse. But of course, if your trial, your single arm trial showed the survival curve here in black, you may think that that's a very significant treatment effect, when really it's selection bias. So this is just an example of where data can make quite a big difference. We wanted to give another, and I'm going to go deeper into this example, but this is some research that our group has done, which is that in order to prevent adverse events, some investigators would like to give anti-inflammatory drugs to patients. So the idea is you give CAR T cells, there's a very exuberant sort of activation of the immune system, you get all these cytokines, it causes associated toxicity. You might think that giving patients drugs to prophylactically, preemptively treat that toxicity, so essentially giving them anti-inflammatory drugs early in the process, would lead to better outcomes. And it turns out that that is true for a particular category of adverse events, which is called cytokine release syndrome, or CRS, and that's this number here. So when patients are given anti-inflammatories earlier in the process, they only experience severe CRS about 2% of the time. Whereas if you wait for them to have symptoms and then you give them the anti-inflammatories, they experience severe CRS about 20% of the time. But when you look at neurotoxicity, the effect is actually, I mean, there's two ways to interpret this. Either the effect is reversed, or I don't actually think this is not a significant, this is not a significant difference, but the easiest way to understand it is that the rates of neurotoxicity are not changed by this approach. And it turns out that there's some sort of underlying biology that might explain this, that has to do with the fact that the way that we treat CRS, the types of drugs that we use, inhibit the interaction of the inflammatory chemicals with their receptors. So it prevents that interaction from happening, but it doesn't actually reduce the overall concentration of those inflammatory molecules. And that actually allows those inflammatory molecules to enter the central nervous system and cause this sort of inflammation. This is another example of where looking at the data, looking at historical data, allows you to make more evidence-based decisions, and also basically highlights things that are counterintuitive about the logic. And at the end of the day, this is really why it's so important to use evidence, basically, to make these decisions and not to just rely on general wisdom. And when we work with sponsors, our goal is basically to say that we make better decisions at every point along the care journey, and altogether that leads to better patient outcomes and a higher likelihood of trial success, as opposed to putting many of these decisions basically up to chance or up to sort of common wisdom, or things where you could very easily believe treating patients sooner is better, or will lead to better outcomes, or giving anti-inflammatories sooner will lead to sort of safer outcomes. But the reality is that's not true. And so so as opposed to a situation where you're sort of relying on sort of chance to make these decisions, you can actually use algorithms to make each one of these decisions in an optimum way from the standpoint of what's known. And that's what we focus on. Okay, so we talked about our patient journey, patient selection, preconditioning, CAR T infusion, recovery, and post-infusion. And the area that what this talk is about, one of the areas that we've really chosen to focus on, also because from the standpoint of getting all the sponsors we work with kind of pulling in the same direction and focusing on something that we think everyone thinks is important, we focused on safety. So here's the sort of here's the sort of outline of how CRS works. So it's an acute systemic inflammatory reaction. This is also something that happens, for example, in very severe like influenza infections or severe COVID-related sepsis. Essentially what happens is you have some sort of insult to the body. It can either be a pathogen or it could be an interaction of one of these immune cells with a cancer cell. It creates cytokines, which recruits more inflammatory cells to the site of injury or to the site where the cytokines are being produced. They interact with the cytokines, they interact with the tumor. That creates more of a positive feedback loop, and you end up with this very significant increase in inflammation. And then the systemic consequences of that are increased, basically, leakiness of blood vessels. So like, that sort of endothelial dysfunction, greater propensity to clot, more fluid kind of moving into the tissues, more fluid moving into the lungs, decreased blood pressure, increased heart rate, fever, and then sort of end organ type effects. So you can end up with sort of hypoxia, acute respiratory distress syndrome. So this is related to the ability to breathe, the ability of the kidneys to function, to be perfused, and then ultimately sort of systemic collapse. So it's a very big problem. But it's something that in order for treatments like this to be given widely, it's very, and I was going to talk about the point of access. So the result of this has been that there are certain sites of care that are experts at CAR T therapy, where they've developed some experience around managing these sorts of adverse events. But the real desire is that these therapies are adopted more broadly, both within the US and around the world. So we work a lot actually with groups in India. There's a lot of development happening of CAR T, both in India and in China. There's a hope that these therapies can be more widely available, but the difficulty of managing these side effects significantly limits who's really able and willing to treat those sorts of conditions. And then this is sort of a little bit of a graveyard of all of the different clinical trials that have been shut down or paused, or clinical programs that have been killed due to systemic toxicity, either cytokine release or neurotoxicity. And many billions of dollars of investment have been lost, and basically there's a lot of value riding on being able to figure out a successful way of managing this sort of toxicity. So in the world of kind of trying to pick a problem where we think we have a differentiated approach, where we have a lot of data, where it's rapidly growing and where there's a lot of value at stake, this is why we focus so much on immune-related adverse events. Okay, and so now we're getting to the part where you can all see a little bit of the methodology, although I think from my perspective, defining the question is honestly so much more important than the methodology, but I wanted to include this in here as well. Okay, so we're going to talk through 3 different posters that we have presented. One at ASCO, one at the American Society of Hematology, and one at the European Hematological Association, 3 big cancer conferences, basically, looking at CRS and CAR T data. So we'll go into the ASCO example first. So top line sort of overview is that what we showed in our ASCO poster was that, number one, we could use routine laboratory test values to track and predict CRS. And the reason that this is important is there had been work showing that sort of exotic laboratory test values were potentially very good predictors of CRS, but the actual assays to measure those laboratory test values took so long that by the time you could actually measure those laboratory tests, the patient would have already experienced the adverse event. So it was nice from a data science perspective because you could look back in time and say, had we known at this point in time the levels of like circulating GP120, these sort of like very fiddly type of analytes, we would have been able to predict CRS. But of course, by the time the actual blood test came back, that had actually happened. So one was we showed that we could do this with clinical lab values. 2, this was the largest data set of this kind where this had ever been done. It was also the most diverse. We looked at both multiple different indications, leukemia and lymphoma. The reason that that's significant is that leukemia, the type of leukemia that's treated with CAR T is like a pediatric leukemia, often like small children, like toddler age. So those and whereas lymphoma typically impacts adults. So we basically showed that this worked for adults and also children. And then all of the validation that we did here was between trials. So rather than taking an individual clinical trial rather than pooling all the trial data and just doing our train and test splitting based off of that composite, we were actually holding at individual trials and showing that we could cross-validate. So the results that we're sharing here, we think are quite robust and actionable. So I won't go through the background too much because we basically talked through it. The goal was to use this very large data set in order to show that we could look at laboratory test values to predict CRS. Overall, this study, which was published around a year ago, had a little over 500 patients in it. Broad age range, actually, yeah. So I said pediatric. We didn't have pediatric patients in this data set. We had adult patients with ALL. But you can see that the median ages were quite different. B-cell ALL had typically younger adults, and this had older adults. We had the racial breakdown, ECOG, whether the patients had prior stem cell transplant, radiotherapy, et cetera, and time since diagnosis. So quite a large, interesting data set. And then this was something that we worked with, there's kind of the version of the machine learning world that focuses a lot on the algorithms and the way that the actual training works. And then there's the kind of side that focuses on exploratory data analysis and feature construction. Partially due to the scale of our data set, partially due to just like the complexity of the physiology and like how much we know about it. We have spent a lot of our effort on feature construction. And we have this particular basically disease model which we use. So we break the treatment experience into these different epochs. There's pre-lymphodepletion. So this is basically from when a patient is enrolled in a clinical trial up until they receive that lymphodepletion chemotherapy. Then there's lymphodepletion. Then there's infusion, which happens at time equals 0 in our model. Post-infusion, this is the acute phase of recovery, and then there's the longer-term phase of recovery. There's basically the first week, and then there's everything beyond the first week. And what we focused on really was measuring both the baseline values and the changes in those values, the average values and the changes in those values over these different time intervals. And there was this very characteristic shape to all the different analytes we looked at. So I'll kind of like, I'll kind of talk you through this. And here you can also see a bit of the sampling bias in the data, which is just the nature of working with you know, observational data sets, basically data sets that were collected for a different purpose. So we see fairly stable laboratory test values over the pre-lymphodepletion period. Again, lymphodepletion is all about killing off blood cells. So, and specifically lymphocytes, then we see a depression in many of the values during that period. Then you actually have infusion. There's a little bit of inertia here where the values keep on trending downwards. And then you have recovery, and these cell counts start to rebound. But obviously you can sort of see, looking at these traces, that there's a fair amount of variance in patients who either do or do not have CRS. The patients who have CRS are actually the orange ones. The ones that do not have CRS are the black ones or gray ones. And what we saw generally is that for certain analytes, there was this divergence. Like they started close together, and then over time, these trajectories would start to diverge. They kept the same shape, but they diverged. So this is just a picture of some of the features that we identified as sort of the most meaningful. So we had platelets. And I remember I mentioned that one of the features of CRS is something called endothelial dysfunction or leakiness of blood vessels. So this is depletion of platelets has a lot to do with that aspect. Something called albumin. Albumin is a protein that is sort of highly soluble and lives in basically the fluid component of blood. And this is also related a bit to sort of the leakiness of vessels. Then we have hemoglobin and hematocrit. So everyone knows what that is. Basically, those are red blood cells, and this reflects basically pretty profound and sustained anemia. Then we also included here were some examples of blood components where we did not see a divergence. So again, neutrophils are another type of white blood cell. They are also severely depressed through the process of lymphodepletion, but we don't see this divergence between patients who do or don't experience CRS. And then we looked at creatinine as just an example, basically like a negative control, like an example of a blood test where it doesn't really change very much from an analyte dynamics perspective, and there's also not much of a difference. And then this is the results of that initial poster, where we basically looked specifically at the changes in the rates of change of these analytes over each interval. And we have an example, this is just the slope, and looked to see where we saw significant differences between the CRS and the non-CRS group. Now, something to note is that in the recovery period, for the most part, this is after the CRS event has actually happened. So these are not predictive, but they are reliably different. And really what we're the most interested in are these measures. So the ones that are either in the lymphodepletion period, so this is fully before the patient receives treatment, or the analytes that appear in the early post-infusion period, but in some cases before CRS has actually happened. And so we identified a few features this way that were significant. And this is like the initial pilot work. Okay, so then what do we do next? The next paper, or the next poster presentation, took all of those features and now fed them into different sorts of machine learning models. And now you'll see, like, given the scale of this data and the complexity of the model, we're not throwing like the most exotic types of models at this particular question. But we have essentially looked at an L2 regularized logistic regression and also an elastic net. And again, did all of our cross-validation in the way that I described, where we're looking for results that can be generalized across multiple different trials. So it's not good enough just to show that we can predict with 80, 20, 70, 30 hold out within a trial. We're really looking for results that are likely to generalize to the next trial. And so when you look at this, as we add in different numbers of features, different categories of features, laboratory test values, vital signs, the models generally, the AUC, the AUROC goes up. And then we have sort of a modest impact basically of what types of regularization we choose, but there's not a lot of sensitivity in these situations. And then we have a little bit of, we ultimately were like the most happy with this model, just because this is fivefold held out cyclical training of the model. But this is sort of where we saw the most stability. And one of the issues that we see a lot in this sort of data is because of the amount of missingness we have in data in trial to trial. Sometimes our feature sets and the stability of these models can be quite poor, but we were able to be reasonably stable here. And when you actually look at the features that we ended up using, we used both the average values and also the rate values, different categories of laboratory tests, vital signs, and then also baseline characteristics. And what you see basically is that this is really about that spline fitting. So we considered both kind of like the average value of an analyte in the epoch, as well as the slope, and then included those as features in the model. And you see some, like, you know, there's some nice things that sort of jump out, like changes in weight. This is kind of an interesting feature. This relates to, I mean, if you've ever seen patients who are in the ICU, but basically an acute increase in weight often is because you're retaining fluid, because either your kidneys are failing or because you're extravasating fluid. So that's something that was sort of interesting and somewhat intuitive in our model. ALT, this is a sort of an acute inflammatory marker related to the liver that sort of jumped out. And then again, and this is a little bit small, but you can see albumin, which showed up in the prior sort of exploratory data analysis, as well as a few other analytes. Those sorts of rates, platelets, those sorts of rates popped out. And then of course, like the baseline values, that's all pretty intuitive. So this is just an example of sort of highest level going from, drilling down. And I realize we have about 10 minutes left. This last one, I'm going to spend 2 minutes on this. This is the work looking at co-occurrence of CRS and ICANS. So this is that question about preemptive treatment. Like, does it actually help? Again, we have our patient background. This is kind of the gist of the work. So preemptive treatment reduces the rates of CRS, does not reduce the rates of ICANS. Then if you look at basically like a 2x2 model, co-occurrence rates of CRS and ICANS, basically there's more severe ICANS happening with non-severe CRS. And we have this matrix, which I think this actually shows a nice picture, which is that in the non-preemptive group, basically more things are populating in this sort of like vaguely diagonal area, that higher CRS, higher ICANS, these things sort of appear to be associated with one another. But when you treat patients with preemptive anti-inflammatories, you essentially don't get high-grade CRS, but you do get high-grade ICANS. But of course, this is sort of, this is more for the data scientists in the group. But if you look at the conditional probability of ICANS given CRS, that's actually not affected by this. So the idea that you're decoupling is actually not really probably the reality, but what's happening is that you're just not allowing high-grade CRS to happen. But within low-grade CRS, the actual relative rates of ICANS are remaining the same, even though it means a higher absolute number. So I'll give you just one more. Well, and so then the next piece here, where we're headed, this is sort of our future directions, is actually taking all of this work and turning it into a medical device. So we're now in the process of submitting the CRS predictive model to the FDA, and hopefully getting into the hands of clinicians so they can actually use it and actively managing these patients. But that will be a talk for another day. Let me pause here, and I will try to stop sharing my screen. And I know there's some questions that the group had that are really related to how I ended up here and stuff like that. So Jimeng, do you have anything you want to prioritize?
I mean, it's fascinating. I don't know how much time do you have. I mean, if you can stay longer, I can. But if you have other things you have to.
I do have a hard stop at noon, but I would be happy to, if you wanted to do a Q&A session during another class, I could certainly come back. I think that would be.
Okay, then in that case, there's maybe some other follow-up things I want to discuss with you on the maybe machine learning part of this, how to improve this current approach you guys are using. Seems like more feature engineering with more basic ML approach. I'm sure you have thought about more of the this days, all this deep learning or tree-based method, right? Whether those can improve and
Yeah, and this is something that we honestly we sort of struggle with a lot, because actually the availability of those methods is very high. So our team loves to throw XGBoost at things.
Right.
Like basically, like everyone wants to throw XGBoost at every single one of these questions. Typically our stakeholders though, and we will often get like a small bump in performance when we use a method like XGBoost. Probably the thing that we've discovered that XGBoost is the best at doing is discovering which patients are from which trial based off of patterns of like the timing or missingness of individual feature values. It's very funny. It does seem to be, this I would say, we often see that if we add in the study ID as a covariate, that will recapitulate what XGBoost is doing. That XGBoost is essentially detecting bias in the data and using that, because every one of these trials that we have, for example, have different rates. And so that's been one limitation. The other limitation has been around sort of the stability of the most important features. That has been like a big limitation. That typically you end up with like a couple of features that everyone knows about that are at the top. And then these deep learning methods or these sort of more sophisticated methods, we end up with a lot of, and I think it has to do a bit with the choice. XGBoost is a little bit harder to tune, but like what sort of penalization or normalization we're doing, regularization we're doing, that seems to be that type of hyperparameter tuning, I think, is really important to develop like a generalizable and also like an explainable result. Because the problem is that if every time you shift the hyperparameters a little bit, the top 5 features that your model is finding completely change, that ends up being a very difficult sort of thing to explain. So I would say our challenges with using the more sophisticated methods have a lot to do with explainability. I would say that's definitely the highest. That's the biggest challenge.
Yeah, that's one of my question. Maybe in the interest of time, I know you have to run. Maybe one there's a lot of questions we sent you, but on the advice side, maybe it's probably most general and beneficial for the students. Like, what advice do you have to give for our data science students or who are interested in this AI for healthcare? I got a lot of questions from them. Oh, do I need to study medicine or study more of machine learning, or what advice do you have for them, right? If they want to get into industry or academia and work in this domain.
Yeah, I mean, I think as painful as it is, one of the most important things I think early in like in the data science career, especially early on, is to interact with the people that are going to use the algorithm or whatever prediction or whatever sort of the output of your data science project is going to be, that you interact with the user and that you understand how they're going to interpret your results, and you get good at communicating with them. And so within medicine, it isn't necessarily something where you have to have a medical background and training to get into this. But I think that one sort of getting buried in the sort of methodology and the sort of technical aspects of the work, but staying at a distance from where it actually interacts with the world. So whether it's a medical device that's performing a measurement that's guiding a particular type of treatment, really understanding what that interface is. If it's like a decision aid, understanding like how they are perceiving the information they're receiving and how that's affecting their behavior. I think that's the most important thing. And then the skill that you develop as a data scientist from that is mostly around communication. It's mostly about, I would say I have almost never, well, not almost never. I mean, I've certainly come across data scientists who just do the wrong thing a lot of the time, but it's much more common that they're doing the right thing, but they're struggling to explain. And so it doesn't have the impact that it could.
Any surprising skill you pick up from school that turned out to be useful in the hindsight? I mean, since you have so many.
I mean, I think that like, I think that my, I put a lot of value in people actually being able to like do the work, you know, that my PhD was in fruit fly behavior. So to give you a sense, like I basically was watching flies like fly around in virtual reality environments and doing kind of crazy things. And it was not really clinical in any sense of it, but it gave me like a lot of space to experiment. I got pretty fast at experimenting, trying out a lot of things. I think that the ability to like prototype, to like take a problem and break it into parts and then actually like prototype the solution. What's really valuable about that is that you have a much better appreciation of what's possible. Like business people will always say, you can just do the strategy stuff. You can figure out, you know, what people will pay for or not based off of the strategy. And that's usually true. Like you can eliminate ideas with strategy, but it's very difficult to generate ideas because if you don't know what's possible, it's very difficult to say, you know, I could train a neural network to draw a picture. There's no like strategy, unless you actually are able to sort of prototype that and show how that works. It's very hard to create those ideas. So I think prototyping, and actually experimenting, that's some stuff that I really value from my graduate training.
Yeah, this is so true. I mean, until you show something concrete, it's hard to just imagine whether that's something useful or not, right? If you show a small interface, just show, okay, here's a chatbot, you can do this, right? And all of a sudden people think, wow, right? But without that, just, oh, here's the GPT-3 model, right? It was this trained hundreds of billions of.
Yeah, here's some like sort of, a bunch of points on a diagonal. And everyone's like, well, cool. Like, you know, like, it's very different if you can actually show what the product will actually look and feel like, or give someone who's not another data scientist a feel of that. That is hugely valuable.
Cool. I know you have to run. I mean, this is super helpful. Yeah. And maybe we can find a separate time to go over more questions, or if, we can try to schedule that.
No, absolutely. I mean, happy to come back and answer questions. If people would like to, you know, get in touch with me directly, I think Jimeng, you can share my email. Jifeng and Trisha, I don't see Trisha here, but I mean, they're actually working with us now. So, you know, we work with interns. We have opportunities for people to come and kind of work on this over the summer or things like that. And, you know, I'm very interested in helping foster this community. So very nice to meet everyone.
Thank you. Thank you, Jacob.
Great. Thank you. Bye-bye.
Bye-bye.